Thank you, Jen. Uh, a very good evening, sir. And I take this opportunity to welcome you and everyone, who has joined us for this webinar on behalf of Hetero Healthcare. My name is Neeraj Prashar, and I'm the sales manager for Helion, which is a CNS division of Hetero Healthcare Limited. So, first of all, sir, thank you for joining us today, to basically discuss cariprazine and basics and its usage for schizophrenia as well as for the bipolar disorders, for the patients. Brief about sir Hetero Healthcare. We all do know that Hetero Healthcare has one of the strongest R&D wings, when we started, and which has been providing, one of the 360 delivery solutions to the pharmaceutical industry across the globe. Hetero also has now more than 25 years of excellence in multiple therapies now, and has been present in, globally around 126 plus countries, with more than 200 products across various therapeutic segments such as HIV, HIV/AIDS, oncology, cardiovascular, as well as neurology. It's a matter of pride to share that Hetero Healthcare also has the distinction of bringing 4 biosimilars, to the market, with 36 plus state-of-the-art manufacturing facilities across India and globally, which have been pioneering in terms of quality as well as innovation. So with this little brief, I would once again like to welcome Dr. Maneesh Gupta, who is with us today. Giving a little brief about Dr. Maneesh, sir comes with an excellence of experience of more than 24 years as a consultant psychiatrist. Dr. Maneesh has done his MD psychiatrist and was a gold medalist from KGMC Lucknow, which was in the year 1999. Also has done his DNB in psychiatry from NAMS Delhi in 2000. Dr. Maneesh also completed his specialist training, which was in adult psychiatry from London in the year 2003. Now, talking about, the previous appointments of Dr. Maneesh Gupta, sir has been a senior consultant psychiatrist at Guru Govind Singh Indraprastha University, Delhi, also at VM Gupta Hospital, Delhi, as well as the Iron Hospital. Presently, sir has his private clinic in Dwarka as well as Uttam Nagar in Delhi. Sir's area of specialization as well as interest comes in de-addiction, anxiety and depression management with suicide prevention as well as in dementia. So with this little brief about sir, I would now request you to kindly take over, this forum. And I would request to share your experience to discuss more, on these subjects, which is cariprazine and its usage in bipolar as well as schizophrenia. So I would request you now, sir, to kindly take over and take us through. Thank you, sir.
Sure. Thank you. It's a pleasure to be here to address the audience and just help them revise about cariprazine, which is one of the newer antipsychotics to treat schizophrenia. Next slide, please. Before I present, let me just highlight the conflict of interest. So this is a paid webinar, and I will be paid honorarium. Okay, so please be aware of that. But of course, I retain my independence in terms of the education content. Next slide, please. So as you know, schizophrenia is one of the most disabling illnesses in the world right now, with a prevalence of 1%. And unfortunately, that 1% are left disabled in terms of activities of daily functioning. They're not able to hold a job. They're not able to work even within the home, do household work. And therefore, it is one of the 10 leading indicators, 10 leading illnesses in the world right now, which causes loss of years of life to people. Some of the signs and symptoms of schizophrenia are positive symptoms, which includes hallucinations, delusions, disorganized speech and thoughts. Then there are negative symptoms, which is anhedonia, avolition, blunted affect, alogia, uh, which simply means that the patient has no interest in doing anything. His face doesn't respond to pleasure, to sadness, and the patient does not feel anything at all. And the third aspect of schizophrenia is cognitive symptoms, which includes memory issues, inability to process social cues, and impaired sensory perception. Next slide. Similarly, cariprazine and antipsychotic is also indicated for symptoms of bipolar disorder, and therefore, just to give you a brief about bipolar, which includes manic symptoms and depressive symptoms at different phases. So some months patient may have manic symptoms, and in some months patient may have depressive symptoms. Manic symptoms are like racing thoughts, talking beyond requirement, excessively being verbally aggressive towards other, having an inflated self-esteem and self-worth, feeling of euphoria. Whereas depressive symptoms, they include persistent low mood, fatigue, loss of interest, lack of concentration, and uncontrolled crying. Next slide. So, as you know, the treatment as such is antipsychotics, which typically are dopamine blockers. Now, we first had first generation antipsychotics, which are now today called as typical antipsychotics. Examples of these are chlorpromazine, haloperidol, fluphenazole. These only block the dopamine pathways in the midbrain, and therefore they are very effective in the positive symptoms. They help to manage the hallucinations, the delusions, and the disorganized behavior. But what they do not manage are the negative symptoms of schizophrenia. And thus we had, next slide, a second generation, also called as atypical antipsychotics. And the following medications are examples of atypical antipsychotics. So we have olanzapine, risperidone, quetiapine, clozapine, etc. Next slide. In this slide, we have tried to explain to you the basic differences in terms of the receptor profile of the antipsychotics. So the typical antipsychotics of the first generation mostly act, as I said, on the dopamine blocker, D2 receptor in the midbrain. But the second generation antipsychotics, they also work along with D2 blocking. They also antagonize serotonin 5-HT2 receptors in the midbrain, which supposedly helps us in ameliorating negative symptoms to some extent. Not to great extent, but yes, to some extent they have been successful. However, the unmet need of patients, whereby their cognitive symptoms were still left untreated and the negative symptoms were still mildly left untreated, led to the development of the third generation of atypical antipsychotics, which are actually dopamine partial agonists. So these do not completely block the dopamine, but they tend to fine tune or balance the dopamine activity in our brain. And therefore, they act both on the midbrain as well as on the frontal cortex of the brain. Examples of these are aripiprazole and cariprazine, which are available in India. Dexpiprazole is not yet available in India. Next slide. The side effects of atypical antipsychotics. Weight gain and diabetes are unfortunately one of the most common and the most disabling side effects of second generation antipsychotics. So while we have been able to help our patients free from delusions and hallucinations, but medicines like clozapine, olanzapine, risperidone, they cause a lot of weight gain and diabetes. The first generation antipsychotics used to cause a lot of movement disorders, except for the symptoms like bradykinesia and tremors. With the second generation antipsychotics, we have the incidence has reduced, but it is still there. So risperidone is known to cause tremors, stiffness, and agitation. The third side effects of antipsychotics is sedation, drowsiness. Patients tend to feel that they are not able to stay alert, not able to stay focused, and hence their sedation becomes a problem. They also complain of low energy, fatigue, and tiredness. Here, clozapine, olanzapine, and quetiapine are the most drowsy, most sleep-inducing ones of all. Next slide. So cariprazine therefore has place in therapy where it will not cause these side effects like weight gain, diabetes, sedation, low energy. And why is that? Because cariprazine is a dopamine balancing agent. Therefore, we tend to use cariprazine most often in younger patients with first episode of psychosis so that our medicine do not induce any negative or cognitive symptoms of schizophrenia. Right? Please also remember that cariprazine is indicated for both schizophrenia and bipolar disorder. So even in young patients who have a first episode of bipolar disorder, we can easily use cariprazine to help reduce the positive symptoms as well as decrease the risk of them having any secondary negative symptoms due to use of dopamine blocking activity. Next slide. So the approved indication for cariprazine in India is for the treatment of schizophrenia, whether chronic or acute. It's also indicated for acute treatment of manic or mixed episodes associated with bipolar disorder or in bipolar mania. Next slide. The dosage and administration of cariprazine. Usually we start with 1.5 milligram a day, and cariprazine can be given once a day. After starting at 1.5 milligram, we can titrate the dose upwards to a maximum of 6 milligrams. Not more than 6 milligrams, as we have found that above 6 milligrams, side effects tend to weigh in much more than the benefits that the medicine is causing. Secondly, in patients in whom we use cariprazine for bipolar depression or in major depressive disorder as an add-on, we tend to keep the doses low. So 1.5 to 3 milligrams is all that we may need in such patients. Next slide. Mode of action, as I said, it is a partial agonist and therefore it tends to balance the dopamine activity in the midbrain. And from the midbrain, the mesolimbic and the mesocortical pathways, they are regulated through 5-HT2 receptors and a frontal cortex. And therefore, the aim is that wherever dopamine activity is more, and therefore it causes hallucinations or delusions, there cariprazine will settle down the dopamine activity. And in the frontal cortex, where the dopamine activity is low, cariprazine will tend to slightly increase the activity and therefore act as an agonist in the frontal cortex. So, specifically, if I mention, it is a partial agonist at D2 and D3 receptors, which partial agonism at 5-HT1A receptors. Okay. There is antagonism at 5-HT2A and 5-HT2B receptors as well. And there is very little to minimal activity at 5-HT2C, 5-HT7, H1, or acetylcholinergic receptors. Thus, this medicine does not cause weight gain, tiredness of mouth, does not cause increase in appetite. And therefore, the side effect profile is slightly favorable to be used in younger patients. Next slide. This is further a representation in as to what we said, the D2 partial agonism, D3 partial agonism, 5-HT2 antagonism, and 5-HT1 partial agonism. Next slide. This slide beautifully tells you the neuroanatomy and the neurochemistry at which cariprazine works. So we see a number of D3 receptors in the postsynaptic and presynaptic D2 receptors, all of which are partially agonized by cariprazine, right? This partial agonism leads to improvement in social interaction, leads to an improvement in the patient being able to feel that she wants to meet people, wants to go out and do some work. It also helps somewhat in the memory impairment so that their memory becomes better. Forgetfulness becomes lesser, focus becomes more, right? The increase in dopamine in the prefrontal cortex, which in turn activates D1 receptor, which further mediates improvement in the patient's wish to be active. So when we say evolution, the patient does not have will to do anything. But if the frontal lobe dopamine activity can increase, then that will reduce. Next slide. This slide shows the pathways which schizophrenia pathophysiology has been implicated. So the mesocortical and the mesolimbic dopamine pathways, which go towards the ventral striatum and the dorsal striatum. Dorsal striatum is known to be the area where dopamine blocking activity would cause side effects. So cariprazine has reduced activity there because of its partial agonism. On the other hand, the prefrontal cortex, where dopamine is lesser, cariprazine would augment the action. Next slide. This table shows a comparative affinity for receptor types based on different antipsychotics that are available in the market right now. And as you can see, cariprazine does not have much action at the D1 receptor. It has fairly good partial agonism action at D2 and D3. Next slide. So I've already spoken about all of this, how cariprazine will lead to a better side effect profile. Next slide. Yes, this slide is very important. The pharmacokinetics of cariprazine is such that it takes only 3 to 6 hours to reach a maximum concentration. But because the metabolites of cariprazine are also pharmacologically active at the D2 receptors, therefore the action of cariprazine lasts much longer. And what we have seen that the actual activity can sometimes last for 1 to 3 weeks. This is an important differentiator between cariprazine and aripiprazole. Aripiprazole is also a partial agonist, but its pharmacokinetics are more linear and shorter. Cariprazine, on the other hand, has a fast onset of action and a prolonged duration of action. As you can see, that the area under curve is quite prolonged, although the maximum peak is reached within a few hours. Next slide. So the key advantage in cariprazine, less weight gain, no increase in QTC. QTC interval is very important because many older generation typical antipsychotics were actually said to cause an increase in the QTC interval beyond 440 milliseconds, which in turn would predispose our patients to having arrhythmias. In fact, one of the older generation typical antipsychotic thyroidazine had to be withdrawn from the market because of the potential risk of it causing QTC increase. Cariprazine's another advantage is it's a once daily dosing, and even if the patient misses the dose off and on after a steady state is reached, we see that the ups and downs in the patient's well-being are very minimal or not existent. This is because, as I said, the long duration of action or the metabolite of cariprazine. Next slide. Next slide. So let me now take you through some of the trials of cariprazine, which have led to its approval by the FDA in the US and the CDSCO in India, and which have led to the evidence and the confidence that we have in terms of why we should prescribe cariprazine. If you can take us to a few slides ahead, can we can you go to slide number, let's say, yeah, there is a slide called Cariprazine Overall Trial Summary. About 10 slides ahead, please. 10 slides ahead. Next, 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 next. Yes, this one. So this table actually summarizes for you whatever was there in the earlier slides, right? So I've used this to make it simpler to communicate my message to you. The overall trial summary of cariprazine. So as you can see, there are three seminal RCTs which led to its approval for use in schizophrenia and bipolar. The first two are in schizophrenia. The third one is in bipolar. So the first randomized controlled trial was a head-to-head controlled trial between cariprazine and risperidone, which sample size of 230 in each arm. The inclusion criteria was negative symptoms of schizophrenia, and the dosing was for cariprazine and risperidone both 3 milligrams to 6 milligrams per day, The trial continued for 26 weeks, so almost half a year, 6 months. And what was noticed in the results was there was improvement in the PANS negative symptom score, there was improvement in the CGI score and the CGI-S score. The side effects were insomnia, akathisia, headache, and anxiety. The second RCT was a more short-term trial. It was an acute exacerbation of schizophrenia in patients who were already known to be suffering from schizophrenia. And these patients were then randomized to placebo or aripiprazole 10 milligrams or cariprazine 3 milligram versus 6 milligrams. Almost equal allocation of sample size, about 150 in each arm. And what was the result? We saw that there were improvements in the PANS overall total score, which means positive symptoms were controlled within a few weeks, and CGI-S score was also controlled. The side effects, as usual, at the doses of 3 to 6 milligrams were insomnia, akathisia, and headache. The third RCT was in actually patients who had breakthrough symptoms of mania. Again, patients who were known to have bipolar symptoms and who had an acute exacerbation. In these patients, cariprazine was used and a trial was conducted between cariprazine and placebo with 150 patients above in each arm. And the YMRS score was found to be significantly different between cariprazine and placebo, thereby proving that cariprazine does have a huge difference in patients who are having manic symptoms. Thus, cariprazine's activity on positive symptoms is also quite good. Since the dose in cariprazine in this trial was up to 12 milligram, we noticed side effects included EPS and tremor. And therefore, once again, I recommend that cariprazine's dose should not be more than 6 milligram when tremors and EPS do not arise. Now, if you can go back, so you can see some of the examples of cariprazine's trials having been submitted to various journals: the Journal of Affective Disorders, the Journal of Clinical Psychiatry. All of these have shown that cariprazine's trials were multinational, randomized, and acceptable by scientists all over the world. Next slide, please. So to summarize, we have cariprazine, an atypical third-generation antipsychotic, which is a partial agonist at the dopamine blocker and a partial agonist at the 5-HT2A. It is less sedative, less propensity to cause EPS, does not cause any change in the QTC interval. There is much lesser chances of having hyperprolactinemia. There are no changes in weight, no risk of diabetes, and there are high chances of relapse prevention, especially in patients who tend to be non-concordant. Next slide. So before I end, this is a brief summary of what my experience with cariprazine has been. So I have used cariprazine in a lot of patients, starting from 1.5 milligram to 3 milligrams. And what I have seen is that it has been very helpful in psychosis without the risk of weight gain or sedation. It calms down the mental agitation of the patient without necessarily making them feel sleepy or drowsy, and it resolves strange or bizarre beliefs of the patient. The cons, however, are the akathisia is a disturbing side effect, and that can happen even at a low dose of 3 milligram per day. Now, we have tried to manage akathisia by using propranolol or benzodiazepines, but it has been difficult to do that. And unfortunately, because of the long half-life of the active metabolite of cariprazine, sometimes we see that the side effects take a long time to receive. One of my patients, once I stopped cariprazine, the akathisia still took about 3 weeks to completely subside. And of course, akathisia is much more common as you go up the dosing ladder. So 4 milligrams, 4.5 to 6 milligram is a higher incidence of akathisia. So what I do in my practice is that I would tend to use cariprazine as a first-line drug for younger patients if they're having psychosis, and I would tend to reduce the dose as soon as their psychosis or agitation was manageable by the family. Next slide, please. Okay, so that is the end of my presentation. I hope you liked it. And if there are any questions, I'm open to taking those questions now. Thank you.
Right, sir. Thank you so much. Jayant, can I request you if you could post the queries into the chat box?
Sure.
Uh, Sir, one of the questions, sir, which has just come up right now is how we could actually differentiate in terms of side effects which do arise from aripiprazole versus cariprazine. So if you could just help us with this, sir.
What I have seen is that aripiprazole, even though it's a partial dopamine agonist, it does not cause akathisia, but it causes anxiety to increase. Now that is different in cariprazine, which may cause akathisia, but does not actually cause an exacerbation of anxiety. This is another reason why in patients who are having mixed episodes of mania, cariprazine is better because it tends to reduce the agitation without causing an increase in anxiety.
Correct, sir. Correct, correct. Another, sir, query which has just come in is like in MDD. This is with retrospective of MDD, like which antidepressant is suitable, to administer along with cariprazine.
Okay.
Yeah, that's a
Uh, I
interesting
mean,
question.
my that's an interesting question. I mean, there are no guidelines as such as to which antidepressant would work better. But what in my
I think
practice is,
this has more to do with your clinical practice and experience, sir, like
yeah,
with your choice, very subjectively, sir. Yeah.
yeah. So in my clinical experience, SSRIs are what I would use most often. And in SSRIs, escitalopram and sertraline are the best and most commonly used. And I have added cariprazine with either both of these at reduced or small doses, and I've seen that it works very well without any drug-to-drug interactions and does not cause any difficulty in treating the depression per se, but to manage the anxiety and the agitation.
Correct, 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 sir. Another, sir, is, one very basic query, sir, which I keep saying, question which keeps coming in. How could we avoid akathisia, sir? Uh, uh, Very commonly, sir,
Yeah.
asked question. Yeah.
Yeah, I mean, the best way to prevent akathisia in emerging neuro patients is to go slow and titrate slowly. So start at 1.5 milligram, see how the patient is responding. If there are any incidences of restlessness, leg pain, sleeplessness, then they could indicate that this patient may have akathisia if you increase the dose. Right? In such patients, you may wish to try even slower titration or may choose an alternate. On the other hand, if the patient responds well to 1.5, tolerates it well, does not report any side effect, then increase the dose to 3 milligram per day for the next week. And again, in the next week, when the patient comes back for follow-up, then we would tend to check and monitor for any emerging side effects, restlessness at night, sleeplessness, insomnia, or any complaint of not being able to sit still, which is what akathisia is. If the patient has any of those symptoms, then once again, I suggest we wait, we reevaluate and reassess the need of cariprazine's dose increase or whether we can manage at that dose. Maybe we can add benzodiazepines or we can add propranolol, which sometimes helps some patients of akathisia. And if benzodiazepines and propranolol does not work, then as I said, you have to reassess and reevaluate.
Right, sir. Right, sir. Right. Thanks for addressing that, sir. Then another question, sir, which has been there is about the sexual side effects with cariprazine, sir, if any you have seen in your clinical practice.
That's good because sexual side effects are one of the pain because of the first generation and the second generation as well. But with cariprazine, I haven't seen any incidents of prolactinemia, and neither have I seen any incidents of lack of libido. Therefore, in that way, this seems to be a good medicine. In some patients, though, there may be some chances of erectile dysfunction. And in that case, I only tend to evaluate whether it is due to the illness per se or whether it is due to the medicine that I am administering.
Right, sir. Right. And that helps, sir. Another, sir, very interesting question which has come in regarding the resistant depression. How cariprazine could be positioned, sir. It could be used individually, or something has to be given add-on. And if it is add-on, what else could be there, sir?
Yes, I would add on cariprazine at low doses if a patient with depression was not responding either at all or perhaps responding very mildly with mild pains. So the usual dose I add is 1.5 milligrams and then increase to 3 milligrams if required. Now, the logic in that is that because depression is also associated with frontal cortex, and cariprazine, due to its modulation of dopamine activity in the frontal cortex via the 5-HT2A, therefore, it might cause patients of depression to start feeling less lethargic, to be a little bit more active, to be able to go out, interact with people. And thereby, some patients have responded very well, even after they failed trial of SSRI. Addition of cariprazine was helpful in that.
Correct, sir. Correct. In a way, sir, this is a bit of a repeat question. So it's asks about, sir, cariprazine, as a molecule, per se
Mhm.
for of psychotic symptoms. So it's more to do with positioning, sir, I think.
Mhm. I mean, in terms of, as I said, for younger generation patients who have a first episode of psychosis, there I do try cariprazine first because I want the younger patients to get well without having any antipathy towards the medication. So no
Correct.
side effects or less side effects would make them more able to take medicine, and thereby it is a very useful drug.
Correct, sir. Correct. Another, sir, query which has been raised is about its usage in pregnancy, sir. Cariprazine for pregnancy. So, if you could share, sir, because I think there have been no papers as such. So, but what's your say on this, sir?
Yeah, I mean, in animal studies, it hasn't been found to show any sort of damage or risk. But as you know, with all new medication these days, patients who are pregnant or in the intention of having pregnancy, they are excluded from clinical trials. So we do not have any data about cariprazine in using in pregnant females. Therefore, I would say it's sort of category where you may have to choose individually whether the risks and the benefits equation suggests that we may use cariprazine.
Correct, sir. I think, sir, it's over the years, we would see that because since the more usage for cariprazine would come in, I think it would
Yeah.
give a better understanding about it. Another, sir, question I think Dr. Umar actually missed when you were addressing it. So once again, if
Mhm.
you for his understanding how to manage akathisia, sir, uh, 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 for the patients.
Okay. As I said, I mean, akathisia is a common thing with cariprazines at a higher dose. So preferably start with a low dose and titrate upwards gradually. And make sure that you assess even at 1.5 milligram after 7 days when the patient comes back. Assess whether he or she is reporting any side effects like restlessness, like pain in the legs, inability to sleep at night, and unable to sit still in one place. And if the patient is reporting any of these, then maybe we would need to either choose to not increase the dose further or may choose to choose an alternative. On the other hand, if the tolerability is good and no effect is there, then increase the dose again to 3 milligram and again reassess. If the patient complains of any of these side effects of not being able to sit still, feeling leg restlessness at night, and those.
Right, sir. Right, sir. Thank you so much. One of the last, sir, queries now is regarding the dosage adjustment, sir, particularly
Hmm.
for elderly patients, sir. So do you do it in a standard way, or, sir, is there a particular way you titrate it?
It's always better to be careful in elderly patients because their metabolism is so slow. And cariprazine already being a long-acting medicine, we need to be very careful of tightening the dose up first. At all, I would give it to an elderly patient. Then I would make sure that I go slow and titrate upwards even further slowly. So maybe give it like 2 to 3 weeks of gap between a dose titration upward and make sure that the patient does not have any signs of tremors or EPS or insomnia or headache. And if the patient is tolerating it well, only then would I increase the dose further.
Correct, sir. Correct, sir. Thank you, sir. That helps. So there had been a few queries, sir, and I think very important ones. And thanks for, sir, briefing them to the audience with your clinical expertise and knowledge. So with this, sir, on behalf of Hetero Healthcare, I want to express, my deepest gratitude, for sparing your time for this informative webinar, today. And sir, along with this, once again, thanks for giving your insights on cariprazine, particularly, with in terms of its usage for treating patients with bipolar disorder, schizophrenia, and even for MDD. I think, which has been very beneficial for the audience to understand and is going to help in terms of, usage of cariprazine, for these patients with schizophrenia, or, we are talking with bipolar or an MDD. And I think with that usage, sir, more experience comes in and more usage, further, grows. And once again, sir, thank you so much. And we look forward towards, more such events where it could be, further, your clinical expertise sharing on cariprazine and other drugs in times to come. And Hetero is very committed to this, sir. And thanks for taking your time out today. And my all thanks to you, sir. Thank you so much. Thanks. Thanks, sir.
Thank you.
Thank you, sir. Thank you so much.
Thank you.